Okay, good evening. It's 7:02 now Eastern Time. It's a cold day but sunny in New York City. Our temperature is about, let's see, it's about 30 degrees. And we are supposed to have a snowstorm. We are very pleased to have an excellent panel again tonight. Chase has done all the work, so I'll let him introduce the panel, and let's get to it.
Great. All right, thank you, Babak. Let me just share the screen here. Yeah, we have a great panel today to go through some cases. I'll be presenting a case myself. Again, my name is Chase Heaton. I'm from UCSF. We also have Dr. Ryan Jackson from Washington University. He did his training at Mayo in Minnesota, and Ryan Lee up at OHSU did his training at Stanford with our guest faculty this morning. This evening, really happy to have Dr. Evan Rosenthal here with us, who did his training at OHSU and has been a professor and the medical director at Stanford Cancer Center since 2015. So we're going to present three really interesting cases and hopefully get some really good discussion out of it. I'm going to get it started here with the first case. We have a 66-year-old gentleman who's a never smoker, with a history of base of tongue squamous cell carcinoma, treated with chemoradiation way back in May of 2013. Really, we had sparse records about what was done. Stage was unknown, P16 status was unknown. He was referred to us about a year later with the PET scan shown here, completely asymptomatic. So I want to just start by seeing what people think of the scan. And really, we often get patients referred in from outside with very sparse medical records. So just want to get your thoughts on how you think about these patients who are treated elsewhere, who you're seeing for the first time for presumed recurrence.
Yeah. So let's see. So he's a year out of treatment, completely asymptomatic. So let's see. Ryan, how would you approach this in St. Louis?
So my question is, what was his primary? Was it base of tongue?
It was a reported base of tongue squam.
Okay. So now he has this new onset. So I would try to get the radiation records to see what his doses were and where the fields were, because for all the patient knows, it could be a contralateral palatine tonsil or something. So this could be a completely untreated field with the left neck. So I would want to know his outside records. I would want to know P16 status, not necessarily for treatment purposes, but for counseling to understand what his prognosis may be after that. A surgery after a P16 positive failure is much different than a status.
I think we have someone unmuted.
How healthy this patient is. I would also set this patient up with our oncologist. A lot of these patients tell you they're swallowing fine after their therapy, but 7 years later, this patient may not be swallowing well, or even a year later may not be swallowing as well as they think they are. So I would want to know their baseline swallowing function before I delve into any treatment recommendations.
Sure. Evan, how would you approach these patients that come to you? I'm sure you see a lot of them. Had apparently successful treatment. Now it's a year later, they're completely asymptomatic, and the medical oncologist usually is the guy that orders that PET, and then they show up at your office with this PET scan.
Yeah, so I mean, I think you have to act on this information, and take them to the operating room and do a biopsy if they're, a year out from treatment, from completing treatment. Then I think it's really important to do that. The other factors that will influence the kind of things you want to know are what the overall function has been over the past year, and what are his other symptoms, because that'll both impact your overall treatment plan. And of course, I assume the PET CT was negative elsewhere except for the two areas that we're seeing as positive.
So your threshold for taking patient back to the OR for a direct exam is pretty low for these cases.
I think you have to have it. I mean, you can try an FNA in the neck. I don't know how big the node is, but it's really important to get pathology. But yes, absolutely. I do have a low threshold so that I can definitively say that yes, we've evaluated you, and we can say that even if the chance is 5 or 10%. That they have a recurrence, you don't want that you don't want to, say come back in 2 months and we'll rescan you.
Yeah, I agree.
I completely agree.
Clinic, this patient would have a recurrence until proven otherwise, based on this scan. We're lucky to have a really expensive, hard to use ultrasound machine in our office. So I would probably try an ultrasound guided needle biopsy with on-site pathology and have our pathologist look at it in my office and tell me right then and there if I'm getting tissue. I don't know about you all, but OR time is very, very limited and turnover time is very, very long. So to take this patient to the operating room just to do a biopsy would cause us a lot of time. I don't know about you guys. Plus, I don't know about you guys with this either, but a lot of our patients come from 3 hours away with this PET scan. They would have been treated with chemoradiation from out in the community, and they'd show up with this PET scan and want an answer kind of then and there. So
yeah. So I guess for the audience, I would mention two things that the panel is emphasizing. Number one, take this seriously. And number two, I don't know if you catch that, but basically post-radiation physical exam is a little bit more difficult. You have radiation changes, you don't know where the tumor is, patient's asymptomatic. So don't expect that if you just don't see an obvious tumor, there's no tumor there. So great point. And also I agree with you that the ultrasound guided FNA is very good. All right, so we have 20 minutes for each case. And I just saw that Dr. McCammon also logged in. So we're gonna use her as our surprise guest tonight. And we'll ask her for a question. So Chase, go ahead.
Yeah, so we thought that PET scan was concerning enough to look into both those lesions. So an FNA was done. It did show squamous cell carcinoma of the neck. DL was performed, and on scope exam in clinic and in DL, really there was no mass seen. Biopsies were taken of the general area of the really just edematous mucosa, which were negative for cancer. So just want to get a sense of next steps here, where we have an FNA positive node. It sure looks like that base of tongue is going to be positive as well, but we're just not getting there with our DL biopsy.
Okay, so let's just stop here. Let's ask Ryan. Ryan, what would you do? So you have a patient, positive PET, you took him to the OR yourself, not anybody else, and you do biopsy and you look around, you don't see a cancer, but you do have cancer in the neck. What's your approach in these cases?
Yeah, I'd still be very concerned about that lingual tonsil. I'd consider biopsying it again, even at the time of surgery, or even doing some kind of minimal resection as a biopsy, more of an incisional biopsy of that lingual tonsil. Because, in theory, the lingual tonsil is probably gone. You're probably just looking at raw muscle that's been radiated at this point. I'd probably want something deeper, because the surface may look normal, but the deeper tissue toward the hyoid bone may not be normal. So in that situation where I'm very, very concerned clinically based on that scan that there's something here, I'd probably want a deeper biopsy. Other options, you could get a contrasted scan, you could get a contrasted CT or a contrasted MRI to see if there's any enhancement in that area. But is that going to change your overall plan? No, I would still get it, but I would want a diagnosis of that tongue base.
Sure. Ryan, OHSU, Ryan Lee, what would you do?
Yeah, so I agree with other Ryan. I would get either a contrast enhanced MRI or CT, mostly for surgical planning, because you're right, it's not going to change whether you need to chase after this or not. But when you go back to the operating room, if you're thinking of doing this either transorally or maybe even a bigger surgery, just something through the neck, it's a good idea to have the dimensions of the tumor or the lesion as much as possible before you go in there, because this may actually be a definitive resection when you go back. Tough case though.
So,
it's really tough.
Yeah, it is a tough case. So let's ask either Susan or Evan. So Susan, you missed the beginning, but 66-year-old had HPV positive base of tongue, treated chemo RT, a year later, now comes up with a positive PET scan. And you biopsy the node and it's positive, but you take the patient to the OR, do a full DL, all the biopsies are negative. How worried are you about that PET scan? And patients are asymptomatic.
Yeah, I'm pretty worried. I also, if I am worried enough to do a biopsy, but the biopsy comes back negative, I will almost always go back at least once and do another biopsy. especially if it's been a fellow or a resident that did the biopsy, I'll want to make sure that I'm doing it. And if I need to, bring in the robot or the laser or do something just to make sure that I've truly convinced myself that I've got that representative tissue, because the difference between doing a salvage neck versus doing an open, pharyngectomy composite resection is just huge.
Absolutely. Evan, would you insist on you won't give up on this? How would you approach this if the first biopsy is negative? Or in your case, you're at the Stanford, patient comes in with a negative biopsy from somewhere else.
Oh, I'd have our pathologist review it. If that review is also negative, I would definitely go back and do biopsies and be pretty aggressive. And I think that that the idea of confirming the primary site is really important. And you could even do the neck and still continue to monitor the primary site, either by going back or repeated imaging. So if that second time were negative, I would then do what needed to be done for the biopsy proven neck, but know that there still could be residual disease that we missed in the pharynx.
So the point for the audience is
case just exactly like this. And we roboted out the base of his tongue, and it was all still negative. And so I did his salvage neck, and it turned out to be no viable tumor in the salvage neck, even though the PET had been positive.
Was the FNA positive?
No, I did not. No, I take that back. I lie. He did have a positive FNA, but the final
yeah, that's usually the case.
Yeah, this case had a positive FNA, and pretty much going along with what everyone said, we thought it would be best to go back, and we used the robot this time. Difficult access to get there, so really just biopsies were taken again, just bigger, deeper with the robot, but not a full resection, which was the plan of the area. It was really down in the vallecula where they couldn't get. Neck dissection was performed as well. Bad disease, as you can see here, gross ENE and skeletal muscle. This was all P16 negative on path, and again, no tumor in the base of tongue. And really just biopsies again, just deeper biopsies with the robot.
Yeah.
Moving forward, just to keep things moving forward here, decided to go back a third time, this time with the CO2 laser, and the help of one of our laryngologists who was there at the time to perform excision of this deep vallecula mass you can see on the CT scan. And that was positive squamous cell carcinoma.
So now you're deep in the vallecula. This is post-neck dissection with a bad disease in the neck. And you finally find the focus of cancer probably deep in the base of tongue, correct?
Mm-hmm.
Okay.
This was again just a biopsy, not a true resection of the area. Positive margins seen.
All right. Let's see, Ryan Lee. What would you do in this case? So one neck has got no vessels in that neck. Now you have a positive, deep-seated biopsy in the base of tongue, and looks like patients are still doing okay in terms of swallowing and function. Correct? Yeah.
Yeah, so I'd give him the benefit of the doubt with my resection. It's written right there already, but to consider a partial supraglottic laryngectomy for this. So you're talking about before you've done the supraglottic. Is that correct, Chase?
Yes. Yeah, that's just a little skipping ahead here, but
yeah, I would. Personally, I'd probably be more comfortable doing an open supraglottic laryngectomy, but technique-wise, that's up to whatever is in your comfort zone. But basically the same thing that you said. I'd try to spare the larynx below the supraglottis and give it some laryngeal.
You're not worried about getting positive margins and, cause
I'm very worried about getting positive margins. But I think if this is truly molecular and this is not extending down to the endolarynx, then you have a chance for a supraglottic laryngectomy on this.
And what about swallowing function afterward? Radiated neck, dissected neck, and now you're doing a
It's chemoradiation, you said.
It's chemoradiation, exactly.
Yeah.
All right.
And it's the kind of patient that you have to counsel extensively, and the family as well, that the expectation may be a very poor swallow outcome and might require a more extensive surgery, unless you decide to go up front and do the laryngectomy right away.
So he was a non-smoker, highly functioning person, and functional after his chemoradiation, and really against removing his larynx. So he opted for larynx-sparing surgery and underwent a transoral partial. Just to give you a sense of what was removed in those, as these are not seen very often, but pretty much the whole structure of the larynx on the left side down to the arytenoids. Did really well after this. Swallowing fine, margins were negative on this resection. And just to close out the case, as these are always difficult, they seem, 6 years later, he finally has his first symptom after all this treatment, and it's throat pain, as biopsy-proven squam. And at this point, obviously, options are a little more limited. And he underwent a TL, partial pharyngectomy, and ALT recon.
Wow. So 6 years later, you may want to ask yourself if this is a second primary, although it's the same place, but
same exact place, could be radiation induced or something hanging out there.
But he got 6 years with a larynx.
exactly.
Yeah.
Pretty good. That's pretty good.
That's good, because looking at this, I mean, I would say salvage neck in a previously treated neck with a lot of extracapsular extension. We think of the successful salvage rate on that as being pretty low. So I'm impressed. 6 years with a larynx and still going without a larynx. So strong.
Yeah.
Do you have P16
So I think that was an excellent case.
Do you have P16 status on the final that new squam that you resected? Because that'd be interesting to know that.
That's a good question. I'd have to look back at that.
Yeah, so this was an excellent case. Thank you. So the point for all of us is, number one is these late-term recurrences can happen. So just, after 4 or 5 years, you have to be careful with the patients. Number one. And number two is you could be creative, and you basically don't treat everything equal, because obviously Chase had a lot of thought about this, that is it possible to get this tumor out with negative margin, and especially transoral and irradiated dissected neck, and they did a great job. But really shows you the challenges of how to manage these cases. Excellent case. Any last comments from Susan or Evan before we move on?
Oh, good.
Okay, perfect. All right.
Great
I guess
case.
it's Ryan's next. Yeah. Ryan Jackson or
Ryan
Jackson,
yeah.
All right.
Yeah, Ryan Lee, you could go third. Yep.
Chase, are you showing the slides, or do you want me to show them?
If you could just share your screen, I think that'll be easiest.
Okay, let me see if
because then you can control.
Okay.
Let's see, we haven't had any, and for the audience, please feel free to ask any questions, and we can ask the panel.
Can you guys see the PowerPoint?
Yeah, you're good.
So I wanted to talk about whether or not to reconstruct these defects. We're talking about
Ryan, you're breaking up a little bit, Ryan. I can just tell you then, because you're breaking up, I'm just going to tell you right now, you can flap them.
Yeah.
Sorry, go ahead.
So to start, you guys hear me?
I think we have a little bit of a background noise. If someone please mute their
I
microphone.
think you're fine.
I hear myself.
It's somebody else.
Okay, yeah. All right.
Perfect.
One more
That
time.
sounds better. So a 67-year-old white man, non-smoker, non-drinker, no significant past medical history, pretty healthy guy, has a history of a right tongue-based cancer from the lingual tonsil, P16 positive, treated in an outside hospital with induction chemotherapy followed by chemoradiation 2 years prior to his recurrence. So he's been disease-free for 2 years. He had multiple scans showing concern for residual disease, but it was being attributed to reactive changes and post-radiation changes. So not an atypical situation that we see in our referral centers. He had progressive symptoms and had concern for recurrence at that time. So he had biopsy-proven recurrence. He had seen 2 different institutions who recommended a lip split mandibulotomy with a oropharyngectomy and a forearm free flap trach G-tube for salvage.
Do you have any pre-op imaging? Okay, there you go. And so it seems like this is a deep-seated recurrence in the base of tongue, correct?
Yep.
And any neck disease?
Yes.
Oh, he did have neck disease.
Oh, wait, no, sorry. No neck disease. No neck disease.
No neck disease. So local recurrence, local failure,
Yep.
2 years after definitive CCRT.
Yep.
And patient function in terms of swallowing and speech?
According to him, it was great. But he saw speech language pathology the same day I saw him in consult, and he had some baseline dysphagia. He had a lot of compensation already from his bilateral neck radiation and chemotherapy 2 years prior. So he was maintaining weight. He was eating a regular diet for the most part, but he had daily symptoms of dysphagia.
Okay. So Chase, what would you do?
Altered as well.
Yeah.
Well, obviously we need to remove this. I think the thing I'm thinking about is the lip split and mandibulotomy. I tried to do my best to not do that. Just adds significant complexity and time to the case. So I like to look to see where it is and to get a sense of how big the pharyngotomy is going to be and see if it's something that could be done both transoral and transcervical. Flap inset is not too challenging if you have a large pharyngotomy. If it's really just isolated the base of tongue and you're not going to have a big pharyngotomy, sometimes you can't get away with not doing the lip split and mandibulotomy. So that's what I'm thinking about right now, but depends on trismus as well and just access to that area.
So how would you decide when you see the patient in the office? How would you decide that this is going to be a transoral or this needs open? Like, can you, for the audience, just walk us through your decision making? How you assess, or you take everybody to OR before you make that decision?
No, sometimes it's made in the OR. I think fairly quickly when you try to look in their mouth and you don't see a tumor and they have trismus, you start just counseling them on the fact that it may be needed. But it's always different when they're in the operating room and they're relaxed and you could really open their mouth wider. So sometimes I struggle for a bit and see what you could get access to. And then at some point you just have to pull the trigger and do the mandibulotomy if needed. But I'll often open the neck, go through the neck and kind of go back and forth.
Okay, so you still have kind of reserve the option of open approach through the neck, transcervical approach to the base of tongue. Okay, Ryan, Lee, you guys are like robot masters of the world. What do you guys do?
Yeah, as Chase was saying, I think a lot of this goes back to patient and family counseling to have them prepared for all possible approaches. You know, this case doesn't seem like something I would spend much time going transorally through, but maybe a smaller lesion, I might tell them I'm going to consider trying to resect this transorally and be prepared during the same surgery to do a transcervical approach, big resection, free flap, all of that, all of the above. So, but I think emotionally preparing them for the full, most invasive surgery that you can imagine to resect this is important.
Yeah, so that's exactly how we counsel them, Ryan. That's perfect, because that's exactly how we counsel them, that we're going to attempt to take this out transorally, but we're prepared to do transhyoid pharyngotomy to get anything we can't get out transorally and be ready to put in a free flap and a trach. These are challenging because when you're seeing these patients in your clinic and you have limited OR time, that's a 4-hour surgery versus an 8-hour surgery in some institutions, depending on what you have to do. Because if you don't know if you need a free flap, it's not like somebody can raise it for you and it's sitting there ready to go. So, you know, to me, that's the difference between a half-a-day surgery versus a full-day surgery. That's the difference between a couple days in the hospital versus, you know, potentially a week and a half in the hospital if they get a fistula or something.
Sure. So let's ask Eben and Susan as our discussant expert. So Eben, how would you approach these? When you decide to do mandibulotomy, transcervical or transoral?
You know, to be honest, I have not done a mandibulotomy in a really long time. You know, the amount of dead space that's created by the mandibulotomy, it's not just the bone that has, the bone complication rate is 10 to 20%, which does cause significant problems, particularly in the dentulous patient, but also the dead space that's created, you know, is a great visualization. I mean, when you're starting out, doing a lip split is a great visualization of the anatomy. But most senior surgeons I know, or mid-level surgeons I know today, would do a transoral plus transcervical through the neck dissection incision to remove this, in part because they do function better. I think that the lip split creates so much destructive, you know, sort of dissection, and your leak rate is higher, your bone complication rate is higher. So so I mean, we we just don't do them as much. And maybe it's just because we're doing so much salvage surgery. Back in the day when you're doing oropharyngectomy as a primary treatment modality, that the results were better with the lip splits. But I don't know how many guys here have really, the surgeons, Chase or Ryan or Babak, what your guys' experience is, but I just don't do them anymore.
Yeah, I completely agree. And we all know how to do them and we can get them, but never underestimate the morbidity of a midline mandibulotomy and lip split. It is, if you have to do it, you have to do it. But exactly as you said, it's a long haul and the complication and everything. What about you, Susan? What's your approach?
I agree with everything you've said. I mean, the lip split mandibulotomies that I've done recently have been for sort of last Hail Mary pharyngectomy, for tonsil failures. But for anything in the base of the tongue, I rely on going through the neck. I feel like you can get a whole lot done through the neck. And if you can access the mouth at all, that just adds to your, abilities. I think whether or not they have teeth is important as far as getting access and maneuvering in there. And then also the question of the neck disease, because often, you're sort of limited by what's opposing the tongue-based disease in terms of is there contiguous neck disease, and are you going to have a big through and through defect, and that kind of will dictate the access and the flap that you need. But I would do everything I could to avoid mandibulotomy in this patient.
Yeah, I think that's very wise, and I hope all the audience pay attention to this, because as you go through your career and you will see these and you will remember those patients that you did mandibulotomy. And as Susan said, absolutely, if it needs to be done, but it's really upon us to, especially with the new technology, to try to do anything we can to avoid it. All right, Ryan, continue.
Although, can I add one more thing?
Can I ask the question?
Yeah, absolutely.
Go ahead, Susan. Sorry.
Sure.
I was going to say, would anybody try to approach this with the robot as a salvage surgery?
You'll see in a minute.
Not this particular one. No.
Okay.
Yeah.
All right.
It'd be something smaller, certainly. And
Ryan,
one more thing I'd add, Bobak, just one, maybe a little less conventional. And we can't see on this imaging, but if this tumor is extending onto the lateral oropharyngeal wall, extending into the medial pterygoid muscles, extending closer to the mandible, something that I've done on occasion is resect the posterior mandible. And if they're edentulous, let them swing. They may have less trismus, and functionally actually do better if I resect mandible and just reconstruct the soft tissue with my pharyngectomy. I've done that
I think
actually a fair number of times, depending on the extent of the tumor, how confident I am that I can get a good margin around it.
Yeah, I think that's a great point. And really the point that Ryan is making is, if you are doing salvage surgery, you need to read that study. You need to read the CT scan and MRI very carefully, and you need to know exactly where the tumor is and how it's the best to approach it. All right.
I'd say you need to put your finger in his mouth and feel how lateral and anterior this goes. So I'll tell you that this patient's floor, mouth, and mandible, mucosa, and everything was clear. You can move this tumor around by putting your finger in through his mouth. So to me, that's a very good sign that it's get aroundable without having to take out bone, without having to split his bone. If I saw this patient in a primary setting when he wasn't chemoradiated already, I would almost certainly recommend chemoradiation therapy for this patient for HPV positive disease. Given how deep that is into the oral cavity musculature, you can see the genioglossus muscle here, and it's abutting that. To me, a surgical resection, whether you put in a flap or not, this patient's going to have some dysarthria because you're starting to mess with the extrinsic tongue musculature of the floor mouth. But in a salvage setting, you really don't have any other options other than palliative care. Yeah. So, we talked a lot about this stuff. We talked about surgery. Is reirradiation an option? Failing within a year or two. I don't know how many institutions would offer reirradiation to this patient. Mine would not, especially off trial, definitely would not. Palliative would be an option depending on the patient's comorbidities and their goals. So that really leads to surgery is the only curative option, at least at our institution. And we talked about extent of surgery. How much do you remove? How much do you do the ipsilateral neck? Do you do bilateral necks on this patient? What approach? We talked about that a little bit. Do you do your lip split? Do you do a transhyaloid transcervical pharyngotomy to get this out? And then does this patient need reconstruction? And I think there's really two schools of thought there that I want to get everybody's opinion on, because I have some colleagues at other institutions that if they do a salvage surgery on somebody, whether it's transoral or whether it's transcervical, either way, that patient's getting a free flap because they've already been radiated. And then, there's a lot of reports out there now that saying patients can do fairly well in a salvage setting without reconstruction, just healing by secondary intention, how we treat them primarily. So it'd be interesting to hear the panelists and everybody's approach, either globally or if it's more patient specific.
So in the interest of time, let's just move it quickly. I agree with you that most of the institutions, especially with less than 2 years interval, are very reluctant for re-radiation, and that makes sense. Palliative, this local disease in otherwise healthy, I think that would be a little bit too much. But surgery seems, I agree with you. So let's talk about surgery. We talked about transoral versus open, and everybody mentioned it. But in terms of if you do transoral, would you reconstruct? Let's see, Chase, what is your philosophy there? Radiated patient, base of tongue resection, transoral. Would you
transoral only approach?
Yeah.
To be honest, it just doesn't seem like this is the case that I would try that.
Yeah.
But assuming we did have a smaller tumor, it's possible. I think that's very patient and tumor specific, and I'd really just have to get a better sense of what I think that defect is going to be like before going in. But in general, like Eben said, I'm thinking flat for most of these.
Okay. Susan?
Yeah. Again, I'm thinking of the, the continuity with the neck and protection of the vessels. And so it would be hard for me not to want to put a flap in there, really just to protect the great vessels, more so than even for function, actually.
Mm-hmm. Mm-hmm. And Eben, what are your thoughts on transoral only and then recon or no recon?
I have seen it done all transoral. It just seems like you just can't see that back cut very well. So
Yeah.
I would say if you're doing a transoral, you're committed to a flap. So if you do it, if you can get away with it transorally, it depends on his trismus and his dentition and stuff.
Mm-hmm.
But certainly a flap in this case is ideal.
Yeah. Okay. Ryan, you want to continue? We have 5 minutes to finish this case.
So we had him set up for to start transorally and see how far we can get and have a short threshold to convert to transcervically. And he was prepped for a forearm free flap trach and everything else. And we actually got around this transorally with negative margins on the main specimen, negative margins on the separately submitted margins. So we felt really good about that. And we hem and hawed for about an hour during the surgery and after the surgery, me and my partner, do we reconstruct it or not? And do we put a piece of asensate skin or do we let it heal by secondary intention? We thought his dysarthria would be the same either way. So we were thinking about swallowing function. Would the bulk of a flap be better than the sensation of not having a flap? So we elected not to reconstruct him. We did a neck on that side. We ligated his lingual artery. Like I said, we were concerned about that as well. The vessels, and this is the final pathology. His nodes on the ipsilateral side were negative. It was a 2.9 centimeter tumor, and we put a Dobhoff feeding tube in on him, and he did well and got his Dobhoff tube out about 3 or 4 weeks after the surgery. He's 2 years out from that salvage surgery. This is what his scan looks like, so you can definitely see the defect.
Oh yeah.
From where we created that. So, we in hindsight made the right choice, but, I think the advantage of a flap is to have a little bulk there. The disadvantage is it doesn't feel anything. So if it was a deeper or bigger wound, I think a flap would have been mandatory. It was one of those really gray areas. That's why I wanted to present it, because it was really fly at the seat of your pants kind of surgery. We had it scheduled for all day, and I think we got a little lucky in that it came out easier than planned.
A great case, and really shows the details of the decision making. And as you said, it's really hard to make the right call sometimes, even as cautious as you. Now, my question is it your routine is if you have local disease, even if the PET scan was negative for the neck, would you always do a neck dissection?
Not always. I really wanted to control his vessels because we weren't reconstructing them. We weren't doing anything like that. So I wanted control of his lingual artery for sure. And we went ahead and just took out level 2 and 3 on that side while we were there.
Sure.
Ryan,
I know you guys published that paper and then the ligate in the external carotid. If you go in here, would you just ligate the external carotid? Ryan Lee?
Would we ligate the external carotid? We would ligate the distal branches of it, and usually I just ligate the proximal external carotid as well at the same time. Yeah.
Mm-hmm.
No, I'm not under any illusion that really makes an enormous difference in the bleeding risk afterwards, but we do it anyways. We're already there.
Jeff, you had a question? No,
I actually have a comment and a question. I put a link in the chat. Carol Thackeray has a first author paper that shows that salvage oropharyngectomy or salvage surgery for these P16 positive recurrences actually offers a survival benefit. So when you're in tumor board discussing and people are like, well, what's the purpose of salvaging? They're just going to recur anyway, or that they're going to die of their disease anyway. There's good data. It's a first author JCO paper that shows that there's benefit. And I just a comment to Ryan, great job on this case. I was curious about how long did it take for the tongue to heal? And I'm sure you're watching it for a while.
Yeah, so that's something I counsel the patients on, even if it's a tonsil. I tell them if you didn't have radiation, you're healing in 2 weeks to 3 weeks. Your pain's going away 10 to 14 days later, and you're going to be healing up the week after that. These patients, I say double or triple it. You're going to have an ulcer there for a long time. Yeah. You're going to have that kind of crud in your throat for a long time. It's going to be weeks to a couple months, not a couple weeks. And I watch them very closely. They have us on speed dial if there's any bleeding problems or any aspiration problems. They're seeing my speech and language pathologist every week after the surgery for a few weeks just to make sure they're doing okay and not getting in trouble from aspiration. But yeah, healing is very, very slow in these patients compared to those that have not been radiated. On tonsil patients, I get a TheraBite for them in the operating room. That way it's rolled into their operation cost, and have them start stretching their jaw as soon as they leave the hospital. That way they don't get trismus of their pterygoid.
Yeah. So one point, the excellent point, the other point I would say that Ryan mentioned, it's tremendous important to work with the speech therapist. Also remember, every time you operate on somebody's radiated neck, make sure you check your synthroid, because a lot of them are hypothyroid, and that's going to cause problems. Let's hear from Eben and Susan, and then we'll move on to ask it. Eben, any comments on this case and your approach for these kind of cases?
No, I agree with everything that's been said. I mean, if you can effectively get around this and not put any asensate, tissue in there, that is always the best. And I'm going to find the paper, try to put it in the chat that was published a long time ago that says if you don't have to replace anything, you shouldn't, because they do overall will swallow better. It does matter what their pre-treatment function was. You're definitely not going to do better than that, and that is helpful for counseling. You're always going to do worse than that, of course, but this is great. I mean, for a patient outcome wise, in terms of not getting a trach, not getting a flap, I mean, this is ideal for this patient.
Yeah, absolutely. Great point about pre-treatment function. I completely agree. Susan, any other last comments for this case?
No, I really, it's a great discussion. I don't have anything else to add.
Yeah, and I thought Dr. Don Reed also joined. Don, would you guys routinely flap everybody? I mean, it's Miami for it. Like, you show up to the hospital, you come out with a radial forearm, isn't it? I think Don is muted. Okay.
He didn't find
All right, Ryan.
All right.
Okay.
Let me see if I can get you my slide.
Stop sharing, so you should be able to take over.
Okay, thanks, Ryan. You guys can see that okay?
Yeah.
Okay. So last case. This is a 70-year-old man who was a never smoker who had a large right P16 positive oropharyngeal squamous cell carcinoma. There's the clinical staging there. He completed definitive chemoradiotherapy in December of 2019. So here's some imaging for you to take a look at. This is pre-treatment, PET CT, and next CT. Yeah, not
where is the tumor?
It's on the left side. Yeah. You want to ask any questions, Bobak, or keep moving first?
Go ahead. Go ahead.
Okay, we'll keep going. So 2 months after he completed treatment, he presented to a hospital nearby with a severe oropharyngeal hemorrhage. They got him intubated, and they have neurointerventional radiology at that hospital. Their services were used to embolize the right facial artery and question mark in front of lingual artery because it wasn't quite clear whether they embolized that. We'll get more to that in a bit. And a community otolaryngologist also performed the tracheostomy at that point. Okay. So what do we stop there, Bob?
So he didn't even get his post-treatment PET scan, correct?
Correct.
And you never see him during treatment, correct?
Mm-hmm. Yeah.
Okay.
At this point, I've never even met this patient before, but this is
I
where
see.
we start.
This sounds like OHSU special. Okay. Because I remember those cases. Let's see. Yeah. Let's ask Ryan. How would you approach this patient? Patient showed a transfer. It's always Friday night before a long holiday weekend, and they send the patient to you. How would you approach these? Because this is kind of like a semi-emergency as well.
Yeah, I think step one is securing the airway like they did. The patient's safe now. They're secure. If they're bleeding still, you can pack their throat. They're embolized. So you can at least take a breath and figure out what's really going on and not panic. I think, once the patient's stabilized from a hemodynamic and a respiratory standpoint, I would want some kind of contrasted scan to see what's really going on, because this is one of two things. This is either tumor that's growing and eroding into blood vessels, or it's tumor that's dying from the recent treatment, and now they have a massive ulcer because they had a collision tumor from their node to their oropharynx. So if the node and the oropharynx both responded, the thing that's in between that are branches of the external carotid artery. So I would want to know what's going on, and I would want to biopsy this patient. If this patient's trached already and they're in the ICU and they're stable from a bleeding standpoint, I would consider doing a bedside biopsy if possible to see if there's viable tumor after I get that contrasted scan.
Yeah, I think that's a great point. And you can basically bring a laryngoscopy set to the ICU and just do it right there. Let's see, Chase.
Yeah, nothing to add. I think this imaging is going to be challenging to interpret, just being so close to treatment. So I think you're going to be obligated to go to the operating room or do a DL biopsy in the ICU to get tissue. Obviously want to make sure they're not bleeding because you're going to be near those vessels. Good contrast and enhanced imaging and go from there.
Yeah, and you do see these cases in neglected tumor, large volume tumors like this. Okay, Eben or Susan, should we continue? Do you have any comment for now?
No comment.
Let's keep going.
All right.
Okay.
Good. So what was done next was actually imaging. This is at the nearby hospital as well. And you could see, obviously, good response to treatment. Well, the tumor is, whether there's tumor there or not is still in question. The problem is, as you guys alluded to, his airway was secured, but they didn't take any biopsies of the oropharynx at the time of his tracheostomy. So airway secure, but this is where we are right now. 2 months after treatment, this is what the CT looks like. You can see a lot of external carotid vessels in close proximity to what's probably a very large necrotic ulcer. There might be tumor there, and there may not be at this point. Okay.
Yeah.
So at this point, this is still a patient that hasn't been seen yet by us. And unfortunately, he's comes to us 4 months after he completed treatment. So 2 months after that last episode, he presents with another severe oropharyngeal hemorrhage, and he's in cardiac arrest.
So 1 second.
Mm-hmm.
So that 2 months episode happened. Patient has stopped. They embolized and stabilized. And then, so has he been living with a trach since then?
That's correct. He's been living with a tracheostomy.
Okay, and then 2 months later, he has another episode now.
Exactly.
And was he able to eat by mouth in these 2 months, or he had a peg?
No, during this, he's G-tube dependent.
Okay, so gets a trach, gets a G2, kind of hovers around, and then 2 months later has a second episode.
That's right. So then
Oh, boy.
now we're 4 months in. Here comes the good Dr. Wax. He wants to tell the rest of the story. So 4 months in, he comes to OHSU, and he has another pharyngeal bleed, cardiac arrest, resuscitated. He's got a trachea, and they switch it out for a cuff tube, and his oropharynx is back. So
Wow.
what to do at this point?
Okay. I think
Most
that
will probably
goes back to it goes back to what Ryan said, the point that you have a very low threshold for biopsying here.
Absolutely.
And, especially
imaging and biopsy.
Yeah.
So this is what it looks like to and company 4 months later. So this looks pretty similar to his scan at 2 months, right? Not much has changed for nothing. Certainly nothing has changed for the better, right? Lots of external carotid vessels in close proximity to the lumen of the pharynx. And so
now,
at this point,
let me ask Chase, if this guy was in your hospital with that 2 months massive bleed, would you consider, even if it is stopped after embolization, would you consider just watching him until 3 months and then the PET scan, or how would you approach these? Like, how worried are you about this guy rebleeding?
So he hasn't been embolized at your hospital, Ryan?
No, he was embolized.
That's correct. Not at that point.
So I would send him right to our IR team here. Take a look again with the CTA, and you had that questionable lingual artery ligation or embolization. So I'd just make sure all these branches are dealt with before biopsy at this point.
Okay.
Can I ask a question?
Yes.
I'm curious what people's practices are around the country, the difference between IR embolization of distal branches versus a covered stent to bypass the entire external carotid system.
Yeah, in general, we have been coiling or putting adhesive in the vessel distally. I haven't seen a lot of stents placed, at least here.
So in Texas, we actually did a lot of covered stents, common carotid to internal, just bypassing the external carotid system with very few complications and pretty good results. So I'm curious. I hope to see some, evidence generated from that series soon.
Yeah. This is an interesting case, but back, if I could just ask a question that
absolutely,
I would probably try to sort out. Hey, Mark, what the hell are you doing? Oh, you got your earpods in?
I've been scolding you.
So I guess my focus would be on what is his distant disease? What is what is the underlying stage of his disease that he would need potentially? Is this somebody who needs to go home on palliative care and that we should be less aggressive? Or is this somebody that, it sounds like they already got chemoradiation, they got recurrence, and what is the resectability of the disease? And if those questions, this isn't a patient who's, going to necessarily, if they've neglected it like this, aren't necessarily going to undergo a lot of complex treatment. So I would definitely try to sort that out very early on, so even in the first episode.
Absolutely.
Yeah,
I think that's a fantastic point. Yeah.
Staging is huge.
Yeah, I agree.
I completely agree. And that's really the challenge here, not just looking at the tumor, but look at the patient, look at their overall status, and don't be afraid of redoing the imaging, even distal imaging. Does this patient have widespread lung mets or bone mets? Or kind of don't get tunnel vision too early in these cases. I guess that's the point.
Yeah. Can I just also interject here? From a palliative perspective, managing impending carotid hemorrhage or carotid blowout, all of that in terms of preventive palliation, in terms of stenting or embolizing or preventing death from exsanguination. And that's a really powerful and imminent issue that we're studying now. But I think, determining the distant disease is really important and the prognostication is important, but then managing expectations and what the eventual cause of death is going to be is crucial, because anticipating carotid blowout at home is really hard.
Yeah. And to comment on Susan's comment, we have a very active IR and vascular surgery, and they have become very comfortable with stenting carotid. And I actually had a patient a couple of weeks ago that similar to this was the larynx, the recurrent, and now it's eroding to his carotid, and they stented him, and he did so far he's doing okay. But those are the options.
My experience with it is mixed. On the one hand, I think you can definitely avoid exsanguination as a cause of death, but I've also then seen patients who've been stented and don't die have really excruciating deaths later, worse than an exsanguination. So I struggle with that.
Jeff, what do you guys do in Philadelphia for these cases? Do you guys stent or do you guys embolize?
I've had it both ways. I had a guy one time. I certainly don't want to be like an expert in this space because that's not a great space to hang out in. But for distal branches of the external carotid, I've seen them coil, and for more like proximal, like there was one where he had a bleeding sort of right off the ECA, right in the ECA. Then that stent worked very well. And one of the comments I was going to make on this CT scan here is that's an awful lot of external carotid artery light up on the CTA here. Yeah. Just for a patient that's been embolized. So I would strongly consider that this patient has been inadequately embolized as a cause of his current circumstance.
Great point. Don? Don, so any comment? Would you like to make any comment from your standpoint in terms of the philosophy in Florida? You're still mute. Okay, let's go on. Ryan, let us know what happened.
I'll keep moving.
This is like a drama novel.
It's sad, right? It's a tough case. So, all right. So these are the questions that most of you presented to us. Okay, are we going to manage this via an endovascular approach, surgical, or a combined approach? And the questions to ask are, what needs to be embolized, if anything, and what hasn't been embolized yet? Do we need to consider embolizing bilateral lingual arteries, and what are the consequences of that? And considering that there might be a lot of retrograde flow that's causing this bleeding too. Okay, and then surgical considerations, trismus, as with the other cases, exposure deep to the mandible. How are we actually going to get to this ulcer? And if there really is cancer indeed present, how are we going to manage that? So as a lot of you have alluded to, a lot of patient and family counseling for all the potential eventualities of what we're going to do to this patient. I'm going to keep moving, and then Bobak, just interrupt, okay? If you
that's okay. I think most of us would be reluctant to go to OR right away. I think we continue the same as you do. But if anybody won't go to OR right away, let us know.
Yeah.
Go ahead.
To your question too, to Chase earlier, what is this? Was there a red flag early on when there was bleeding at 2 months after the treatment had been completed, and what could anything have been done differently then? And I would suggest yes, but I'll show you some more films later. Anyways, this is the angiogram from the contralateral side. This is the left side showing all the different branches of the external carotid, and I'll show the right side as well, the side where the tumor was. So facial, lingual, superior thyroid coming down as well. These are all intact on the left side. Okay, at this point. This is the right side. Okay, this is after his prior embolization at the other hospital. Okay, so you can see coils for the facial artery. You can see some distal coils as well there, and then you can just barely make out, circle it here, a blush along the pathway of the lingual artery. Okay, so lingual artery isn't supposed to have this large filling in this particular area. So what they were concerned about was a pseudoaneurysm of the lingual artery on this side, and it clearly had not been embolized or coiled during his original embolization procedure. Superior thyroid artery, internal carotid, all of those appear intact. So then in our neurointerventional suite, again, this is the blush along the course of the lingual artery that we think is pseudoaneurysmal disease, and then the coils in the facial artery, different parts of it. So our neurointerventional radiologist decided to inject onyx and embolize this portion of the lingual artery where we think he's bleeding. Okay. So then at that point, question is, what do we do next? So the airway is secure. It's got a tracheostomy. Our interventional radiologist actually decided to embolize the contralateral lingual as well after discussing with us. There's risk with this because, of course, as I think most of you know, this can necrose the tongue. And he's fortunate, and I'll tell you right off the bat, it did not in him. Okay, and that was done after discussion with our team actually, and fortunately his tongue did not necrose. Okay, so then we decided to take him to surgery. And this is where a lot of the extent of surgery comes into play. We had discussed them at a bare minimum, taking a look in the operating room and getting an idea. A lot of it was for prognostication, to take a look how big this ulcer is. Is there any chance that this ulcer, whether there's tumor there or not, is going to heal by itself? If there's tumor there, it wasn't going to, and we needed to get tissue to confirm. The other problem with these large ulcers is that you can't biopsy the entirety of the ulcer to determine whether there's tumor there or not. So when we're counseling patients, it's not possible to tell them with certainty whether there's tumor there or not until we resected all the necrotic tissue, if that's what they decide to do. In any case, for this patient with severe trismus, I went in and actually did a posterior segmental mandibulectomy. So that's from the TMJ down to the posterior body of mandible, just distal to the angle of mandible. And we did a partial pharyngectomy, resected all that necrotic tissue, partial glossectomy as well. And again, all this is done counseling patients. You may not have any viable tumor in there, but I don't expect that you'll be able to heal from this ulceration. What we found actually intraoperatively was he actually had a pseudoaneurysm of his internal carotid artery at the skull base, which I didn't see on his preoperative angiogram, and I don't think anyone else saw it from the interventional radiology suite as well, all the way at the skull base. Okay, and so I called vascular surgery in to take a look, and they decided at this point this is too risky to leave alone, and they ligated his internal carotid artery. So took some significant risks during this surgery. Always important, I put here, to get a second opinion before you do something this potentially catastrophic or this risky.
Yes.
And again, I'll tell you, I'll cut to the chase that he actually fortunately did not have a stroke, thank goodness. But he absolutely could have at this time. We did soft tissue reconstruction only, and we let him swing just with the ALT, free tissue transfer, both skin and muscle. Okay. So this is what the flap looks like afterwards. You can see, just comparing to the left side, mandible's been resected. It's hard to tell in these two slices, but flap, full lining of the pharynx. Yeah, it is insensate. It's not functional, but we've basically controlled his risk of bleeding. You know, in the end, I'm not sure whether he ever actually bled from his internal carotid, but we felt a lot better after vascular surgery colleagues made the call to ligate that. It's a tough call though, because that patient could certainly have stroked during the case, a catastrophic stroke.
And Ryan, was there tumor on path?
No.
So,
Wow.
So no tumor on final pathology,
Okay.
which is one of those things. Again, you never know, right? In the end, we see. Unfortunately, we're getting well versed in seeing these post-radiation wounds in the oropharynx, and some of them do, and many of them don't have any viable tumor, but they just simply won't heal. And then one of the things we've noticed, and it's purely theoretical, but taking out at least a portion of the hyoid bone that might be necrotic and not allowing the overlying soft tissue to heal is probably pretty important to do during these procedures, getting any necrotic devitalized tissue out of there. So this man, he's severely dysarthric, but he's healthy and he's active. He's got a life outside of, despite having gone through all of this severe morbidity too. Sorry about that.
So let me get this right. You ligated bilateral tongue, the tongue didn't die. You ligated internal carotid, he didn't stroke out.
Yeah.
This guy is kind of Superman.
He is a very fortunate man, right? And this is not something that we can probably do on everybody and expect the same outcome, but a healthy man coming in. So very quickly, is that okay, Bobak? Last minute? Or?
Yeah, please.
Yeah. So the lessons that we learned from this, and this is very similar across all these similar cases, is recognizing when is a wound unlikely to heal. Okay, so during that first evaluation at the nearby hospital, would have been a good time to get a good look at the wound and understand what's the probability of this is actually going to heal by itself, or are we going to be back again in a few months or a few days. Okay, what vessels do you embolize with IR? I certainly don't recommend bilateral lingual artery embolization routinely. This man was fortunate, but I've also seen it go the other way where patients have lost their entire tongue. Definitely had to be on that end of that. And how and when do you secure the airway for a patient? If they have a oropharyngeal bleed and they have an ulcer and you embolize them and ultimately you send them home without any surgical management of the necrotic tissue in the oropharynx because you're hoping they'll heal, what do you do with the airway at that point to protect them? Tough question to answer. And then, as we all have discussed already, is there residual residual tumor there, or is this tissue necrosis alone? And counseling patients that we honestly don't know the difference often until we've done something definitive surgically. We talked a little bit about mandibulotomy versus mandibulectomy, or neither. And as with the other surgeons, I have not done a mandibulotomy as an attending yet. I've sort of tried to find any other alternative to get around that. But certainly, sometimes I wish I had to make some things more simplistic for insetting. And then lastly, being generous with your reconstruction. If you're just doing soft tissue reconstruction, don't try to skimp on the tissue that you provide for that closure. It should be bountiful tissue to close without any tension. It shouldn't be struggling to make the flap reach to all areas of the defect to cover it up. So, things that I've learned along the way. Spend time to explain to the patient and their family what are the potential outcomes and potential extent of surgery that they may have to undergo and the morbidities of these two. Okay.
Well, fantastic cases. Thank you. It was truly unique and amazing job getting that. The question from audience was, how long did you wait after that cardiac arrest, and did the patient have any cardiac issues? How did you guys clear him before you take his internal carotid?
Good question. So obviously he was in the intensive care unit after that, right? And he was actually alert and lucid, which is always a good sign the day after his arrest. And then we were able to have him lucid enough that we could have that discussion with him and his family, what he would want to do and what were the potential consequences of a big surgery that he ended up having. So within I'd say probably within about a week or so, we got him to the operating room and committed to doing this big surgery.
Fantastic. Okay, two last comments from Dr. Rosenthal and McKeown, and we're going to finish. Evan?
No, this was great. I have to go, but this was a great. Thank you so much for including me.
Of course. Thank you. Thanks for having us. And Susan, any comments?
Yes, terrific cases, really challenging. And I think the common theme is often soft tissue reconstruction with a free flap or a PEC is more about protecting those great vessels than it is about reconstructing the upper aerodigestive tract, which can heal on its own.
Okay, well, great though. It's 8:04 Eastern time. Thank you so much for joining us. This was a fantastic session. Thank you, Chase, for arranging the session. Thank you, Ryan Jackson and Ryan Lee. And of course, our experts, Dr. McCammon and Dr. Rosenthal. We will see you in 2 weeks on March 3rd. We have an amazing session on osseous recon and bony reconstruction. Have a great night. Stay safe.
Thanks for having us.
Yep. Stay warm, everyone. Take care.
Thanks, everybody.